Hi, my name is Connie McClumas and you're watching a video on the management of convergence insufficiency. When a patient is diagnosed with convergence insufficiency, we have a range of conservative treatment options in order to assist the patient to improve their convergence. Generally, we'll treat patients who are symptomatic, so they've come in with those asthenotic symptoms, for instance. And this relates back to how old the individual is and how motivated they are to undertake the exercises. If the child is very young or the person is not motivated to undertake the exercises, then it's likely that you'll be unsuccessful. And you want the patient to be in general good health when they're trying to improve their convergence near point. In terms of prognosis, if the patient has a primary CI, then these patients respond very well to treatment. And the effects can be quite long lasting. They can last for years at a time. And once you've taught the patient the tools to use to improve their convergence, they can actually go back to using those exercises from time to time if they feel that their symptoms are returning. Now, the aim of treatment is clearly going to be to alleviate the symptoms that the patient presents with. And to do this, what we will do is improve convergence, and that will be the convergence near point. It may also include jump convergence and voluntary convergence. And we may also set about improving fusional convergence amplitude and specifically fusional convergence or positive relative fusional vergence. In terms of our treatment options, the first thing we should always consider is there an underlying cause? If this is a secondary CI, then we need to deal with what's causing the convergence insufficiency. Okay, once we've done that, our other options are optical correction, so correcting the refractive error or prisms. We can prescribe a series of orthoptic exercises, which I'll discuss in a moment. And then surgery is debatable, but I'll mention it in a moment in terms of whether it can assist patients with CI. In relation to orthoptic exercises, I've indicated here, I've given you some sense of the type of regime we provide patients with CI, and this actually you can translate to any type of orthoptic exercises you give patients for any reason, CI or not. But generally you should give the patients these exercises to perform at least a couple of times a day, and if possible 3 or 4 times a day. And you do it for short bursts of time, so 2 or 3 minutes, up to 5 minutes, but nothing beyond that. You need to make these exercises such that they're manageable in a patient's day-to-day life, and that you don't do excessive amounts of exercises. I've indicated there also that it may take 8 to 12 weeks to complete your treatment regime. Now, sometimes it can take as little as 2 weeks to see a good or significant improvement in convergence in the patient's symptoms. It will depend on the condition itself and then obviously the patient's compliance to treatment. Okay, so here I've listed the various options we have for our patients. So first, is there any refractive error that may be contributing to the patient's difficulty in maintaining convergence? In which case we would prescribe accordingly. Now again, go back to your principles of correcting refractive errors in a patient with an exodeviation, because what we want to do is assist convergence with the refractive correction. So undercorrect hypermetropia, fully correct myopia, and fully correct astigmatism. In terms of prisms, usually this is a last resort option and only utilised if orthoptics or glasses are not assisting the patient. So in essence, we give base-in prisms to these patients because they have an exodeviation, and this essentially gives the patient BSV without the need to actually converge. So again, we would prefer to actually improve convergence rather than give the patient base-in prisms which don't require them to converge. Another way you can use base-in prisms is if your patient is struggling to maintain BSV at near, you might commence giving them base-in prisms and then introduce orthoptic exercises with the base-in prism and then wean that patient off the prism as they improve. Okay, let's go over the orthoptic exercises that you can prescribe. Firstly, if the patient experiences suppression when they break, so they don't appreciate diplopia, when they no longer can converge, then you must prescribe an anti-suppression exercise. And usually patients will do best with colour filters in this particular instance. You need to then be confident that the patient is experiencing diplopia in order to move on to other orthoptic exercises, because the other orthoptic exercises obviously rely on the patient seeing two and then trying to make them one, or trying to make those two images one and achieve BSV. So the first thing we usually prescribe is simple convergence exercises. So these are our pencil push-ups, where the patient might take an accommodative target at arm's length and bring it closer and closer towards their nose until they see two. Once they see two, they make the effort to make it one. Hold, hold, hold single vision at that distance and then bring it in closer until again you see diplopia, or the patient sees diplopia, and then again they try to make it one. When they've maintained single vision there, they keep going. And in doing that 2 or 3 times a day, for a few minutes a day, you will see a significant improvement in their convergence near point. We can then move on to jump convergence. With jump convergence, we want the patient to appreciate diplopia. So if you've got a dot card, for instance, what you want to do is look at one dot and see that as single and one, and then have physiological diplopia of the other dots on the card, which indicates to the patient that they have BSV at that moment. And the patient jumps between the dots, continually appreciating diplopia and continually having confirmation that they have BSV. Okay, we can also go about improving a patient's fusional convergence, in which case we would give the patient a base out prism bar and allow them to improve their fusional convergence. We could also prescribe positive relative fusional convergences, in which case we would give the patient stereograms and request that the patient make a vergence movement ahead of their accommodation. And finally, the most difficult component is that once your patient has successfully improved their convergence, you may try to have your patient undertake voluntary convergence. This can be difficult. Some patients may not be able to achieve it, but it's usually one of the last things that you would prescribe in terms of orthoptic exercises once you've been successful in the other elements. And finally, I mentioned earlier that surgery may be an option for CI. The evidence is lacking in relation to this, but there have been some studies that have shown that it may be effective in patients with larger angle exodeviations and CI. So overall, it's rarely performed. You would only consider it if all other options haven't worked, particularly you've tried base in prism and the patient cannot maintain single vision. And in this instance, what you could do are medial rectus resections, but in doing so, there is a risk that you may create an esotropia for this patient. Okay, that brings us to the conclusion of this video. Thank you for watching.